Yeah.
Turn it down. I can't see. Yeah, that's it doesn't look bad without it. I can't even look at it. Just turn it down. Turn it on. That's good. Okay.
And whenever you're ready, sir, it's 6:59 yeah,
Yeah,
it's
as soon as it
6:59
goes to
p.m.
7, I'll tell you. Okay, start letting them in.
Hey Doc, how are you?
Good, good, good. We good, Hussein?
Yes, sir, we are.
Okay, I'd like to welcome everyone to the January 14th Grand Rounds. Hopefully, everyone had a great holiday and looking forward to a great year. Dr. Hussein told me we have some very, very good cases. We've been limiting the number of cases that we can do now so that we can spend more time on it. But he said you'll be very happy with the diversification of cases that we have today. So, first of all, I would like to thank Dr. Hussein Tarek again. He is the clinical director of ITX Pros. He coordinates all the cases and the reformatting, and he does the treatment planning, as you know. We also have Dr. Rick Robinette on the line for any questions that you may have. I do have a lecture to give, or what I call clinical pearls, which is a very important one tonight that hopefully people will ask some questions and we'll talk about that. If you do have any questions, you can put it right here into the chat and Dr. Robinette will get right back with you. So with that being said, let's go right to our quick little lecture that I want to talk about. And what I like to talk about
Dr.
tonight
Resnik, would
is,
you mind sharing your screen, sir?
okay. Maybe I need to share the screen. Okay, sorry about that. Here we go. Okay, so we'll start that over. Again, here is Hussein, my hero. Thank you very much, Hussein, and Dr.
Thanks.
Robinette. And here's where the chat is. Okay, perfect. So thank you. So let's talk about prophylactic antibiotics. Now, why am I going to talk about it 7 o'clock at night after you work all day? Well, as you know, I do a lot of legal work defending dentists, and I've had two cases within the last 6 months dealing with prophylactic antibiotics. Even though I talk a lot about this in the courses, there's still a lot of confusion about it. So I just want to talk about it. There's four areas that I see that I call them pitfalls with prophylactic antibiotics. Number one, standard of care. Is it standard of care? Second, which antibiotic do you use? Third, what is the dosage? And fourth, what is the duration you should be using? So let's first talk about prophylactic antibiotics are used to minimize infection. Basically, the procedures we're doing have a high risk of bacteria and a high risk of infection. If we look at the benefits of antibiotic prophylaxis, we know it prevents infection. We know it reduces implant failure. We know psychologically that if you give antibiotics to a patient, they're going to feel better. If you don't give it, then that patient's going to wonder because one of their friends probably had an implant and they're going to say, why didn't your dentist give you antibiotics? So there is a psychological component, which I've seen many times. And then there's a significant legal aspect to antibiotic prophylaxis. If we go back to, remember, I always talk about Peterson, Larry Peterson. who's an oral surgeon in Ohio. He has written all the textbooks, all the articles on antibiotic prophylaxis, not only in dentistry, but also in medicine. And he has 5 principles. So the first one is that to give antibiotics, you must have a significant risk. So these procedures that we're doing, do they have a significant risk? Well, yes, we're placing a foreign body or foreign, as in bone graft material, into a human. So yes, it does. If we look at some of the studies, here's one about 2.4% for implants, about 10% of patients will get infected. If we look at another 2 studies, here it's about 11%. So as you can see, it does happen. More importantly, the American College of Surgeons look at every surgery done in the body and they put it into one of 4 classes. Dental implants is clean contaminated, class 2. American College of Surgeons say that runs about a 10 to 15% chance of getting infection. So if we look at a clean contaminated surgery, if we do use antibiotic prophylaxis, aseptic technique, it reduces that down to about 1%. So that does make a lot of sense. If we look at non let's not look at any of the bias studies or the manufacturer studies. Let's look at very, very good scientific studies. Probably the biggest, largest dental implant study that was ever done was 29 VA hospitals, 3 dental schools. It's called the DICRG. What they found is patients who received antibiotics prior to the surgery had 2 to 3 times less failures. If we look at that same study and they categorized or evaluated less experienced surgeons, less than 50 implants placing. And if you utilize antibiotics, 7.3 increase in survival rate with antibiotic prophylaxis. So you can see it is definitely indicated. So what are the consequences if we do get infected? Well, as you probably heard me talk many, many times, if you do get an infection, they're very hard to treat. 89% of dental implant infections or bone grafts end up in failure, even though that you give antibiotics. If we look at 65% of those require removal of the implant and the bone graft. So what does that tell us? You don't want to get an infection because they're very hard to treat and they have a very high morbidity. If we look at placing an implant and going back into that same site, 71% survival rate. If it fails twice, you go back in the third time, that goes down to 60%. So you can see you don't want to end up with a failed implant. And that's why we have the pharmacologic protocol. And as you know, all of our procedures, we evaluate patients by their medical history and also the invasiveness of the procedure. In medicine, the prophylaxis is dictated by the invasiveness of the procedure and the type of procedure. So it's the same with what we're doing. That's why we have 5 categories. As you see, every type of implant, bone graft should have antibiotics. However, the duration and the dosage will change. And we'll talk about that here in a second. If we look at what is the ideal antibiotic, that is principle 2. What Larry Peterson said is you pick and use the antibiotic that is specific for the bacteria at the surgery site. Well, we have all these antibiotics that we can use in dentistry. So which one do we use? Well, if we look at, let's just look at what type of bacteria causes infections. It's strep. The number one bacteria that will cause our bone graft infection or an implant is going to be strep. Secondarily, anaerobic gram-positive, gram-negative. However, strep is still one. No matter what, all 3 of those bacteria classifications, the number one antibiotic is a beta-lactam antibiotic. We all know that beta-lactam antibiotics are penicillins or cephalosporins. So if we look at the ideal antibiotic for dental implant bone graft procedures is going to be amoxicillin. Now, the problem that we have is penicillin allergy patients. If we look at if our patients cannot take a penicillin, we know from studies that the infection rate goes up significantly. Here, 6% failure rate 3 times if they can't take a beta-lactam antibiotic. Here's another one, 10 times higher failure rate if you can't take penicillin. So the bottom line on this is we want our patients to take a beta-lactam antibiotic. What have we always defaulted to in dentistry? Clindamycin. So what's the problem with clindamycin? Everyone has heard the bad things about it. Let me just review it real fast. First of all, it's bactericidal, not bactericidal. We always want to use a bactericidal antibiotic. If we compare amoxicillin versus clindamycin to infection rates, here it is. It's significantly higher if they're taking clindamycin for implants, socket grafts, and ridge augmentations. Significant change if they're taking clindamycin. We know that now clindamycin has a negative effect on bone metabolism and actually implant integration, so bone growing into the implant. We know it reduces alkaline phosphatase, which is needed for the calcification of bone. We know for sinus grafts that if you use clindamycin, it actually increases the chances of a post-sinus infection. And if we just look at implant failure rate, here's a study, almost 6 times greater failure rate. So the bottom line is we don't want to be taking clindamycin. Also, clindamycin increases the bacteria Prevotella. Prevotella is one of the organisms or bacteria that actually colonizes and causes peri-implantitis. So this just a lot of bad things about it. Even though the ADA didn't really address that, the reason that they discontinued or recommend discontinuation is because of C. diff getting pseudomembranous colitis because of the clindamycin. But again, that's just another negative for it. So if we look at what are our alternatives, and this is our problem, which antibiotics should be used? And this is where, at least the one of the lawsuits I was involved with, that unfortunately we didn't have a defense because the doctor used an antibiotic that was not specific for the dental implants or the oral bacteria. So if we look at what should be used, it should be a beta-lactam antibiotic, and we should immediately default to cephalosporins. Now you're going to hear from, I know I was taught in school, it's 10% cross-reactivity. That is actually incorrect. If we look at patients who come in your office, about 8 to 12% will report an allergy to penicillin. About 90% of those within that 8 to 12% will have a negative skin test for penicillin allergy. So what does that mean? The majority of your patients aren't really penicillin allergy or allergic. The myth in medicine, and this is well documented now, especially in pediatrics, is that 10% cross-reactivity. It's actually less than a lot of other antibiotics. It's less than 1%, which is what most other antibiotics are. The reason is they just had poor scientific research on that. They thought because the penicillin has a beta-lactam ring, the cephalosporin has a beta-lactam ring, that means cross-reactivity. It's actually the side chains. It's the R1 side chain. And as long as the cephalosporin has a dissimilar R1 side chain, you can give it 100% of the time. So if we look at first generation cephalosporin, some of them do have an R1 side chain that's similar. However, second, third, fourth, fifth generation, none, very dissimilar. So if we look at some of these articles out there, these are just 4 that show you can safely give cephalosporins to penicillin allergy patients if it's a second, third, or fourth generation. Therefore, if we look at what our options are, one would be Keflex. Unfortunately, Keflex is one of those cephalosporins that does have a similar R1 side chain. So that is not going to be good for a truly allergic penicillin patient. If it's non-anaphylactic, not a problem. My go-to or my recommendation is Ceftin, which is cefuroxime. It's a second generation, no cross-reactivity. And the more popular one now that we're using, especially for sinus grafts, is Omnicef or Ceftonir. This is a third generation, 0% cross-reactivity. So if we look at these 2 Ceftonir and sulfurazine, they are excellent against staph and all the strep that I talked about and all the anaerobes. So when we look at what are people using out there, and this is what I see a lot of, Zithromax. Unfortunately, Zithromax has high resistance, especially against oral strep. So it's not really good, very poor coverage. If there's only one study that I've ever been able to find, it showed about a 31% implant failure rate if you're using that as an antibiotic prophylaxis. Second, if you look at the ADA, it says use doxycycline. The problem is doxycycline is very poor against oral strep bacteria. And then we have resistance and photosensitivity issues. So the bottom line is this would be the ideal drug classification, quinolones, and we use those. If you look at any of our prior textbooks, I had this in there as our go-to because they were great, but now the FDA put a black box warning on it, and you should not be prescribing Levaquin or Avelox. So that is another problem. So now that I thoroughly confused everyone about this, let's come up with a summary. If you are performing an implant procedure or a bone graft procedure, please give the patient a beta-lactam antibiotic. If they do have an allergy, what I see more of now is referring the patient for allergy testing, which is a good thing to do because the majority of these patients aren't allergic, and it's probably good for other problems that they may have where they would need a penicillin type of antibiotic. If it's a non-anaphylactic reaction to penicillin, they can use Keflex, Ceftin, or Omnicef. If it is a true reaction, they've been diagnosed as a true penicillin allergy patient, they could take Ceftin or Omnicef. I have two question marks there. The reason is, unfortunately, our pharmacists don't keep up with the literature, and a lot of pharmacists will not fill that just because they default to, if it's a cephalosporin, they should not prescribe that, even though that is untrue. And then we have to go into the Zithromax or the doxycycline, which has a very high infection rate, as I said. So Ceftin, sulfurazine is the first one, Ceftonir the second. And if you have to, and the pharmacist will not, or the physician will not allow it, Zithromax or doxycycline. However, you have to inform the patient they are in a higher risk category, and it's about informed consent. It's not your problem. Don't make their problem your problem. As long as you inform them that it's a higher infection rate, that's all that you can do. Follow our pharmacologic protocol. This is in the textbook. So read that and make sure you understand it. The last thing I'm going to talk about is the timing in the dosage. You need 2 times the therapeutic dose prior to the surgery. What does that mean? We need antibiotic in the bloodstream before we pick up the scalpel. If we pick up the scalpel and there's no antibiotics on board, then this patient is at high risk of getting infected. Why is that? The greatest bacterial insult this patient's going to have is when we start flapping the tissue, when we perform osteotomies, and then we're putting a foreign body in that bone. If they don't have good blood levels, they're at a greater chance of getting an infection. And post-operatively, you can't catch up. And studies have shown that. So be very, very careful when you're doing an implant procedure, bone graft procedure, at least 1 hour prior. If you're doing a sinus graft procedure, remember, we give it 1 day before because there's poor perfusion and the antibiotics do not get a high enough blood level into the sinus mucosa. So with that being said, the bottom line is make sure it is standard of care. There are articles that will say you don't have to give antibiotics, but I'll tell you what, if you do not give it, you're going to have to explain why you did not give it. And that is very hard to explain, especially to a jury. So please give the antibiotic. Depending on the invasiveness of the procedure, follow our pharmacologic protocol. with that being said, we have a lot of cases to go for. Any questions on any of that? Dr. Robinette is available and he will answer any of those questions. So go for it, Dr. Hussein. And who's our first doctor?
Thank you, Dr. Resnik. First case is for Dr. Kennedy. Dr. Kennedy, would you mind unmuting yourself and presenting your case to Dr. Resnik, please?
Hi, Brian. How are you? Is Dr. Kennedy there?
Yes, sir, he is.
Doc, how are you?
Good, good. How are you?
Nice
Okay,
to
what
see
do
you
you
guys.
have for us tonight?
I have a this is a patient, Jay Tackett, who presented with very little dentition. He has been in a upper and lower partial denture for 20 years.
Okay.
He wanted to talk about a fixed solution, and we had kind of talked about several different things. One, obviously, an all-in-X, and then the patient would like to do is patient would like to do an overdenture,
Okay.
RP5.
RP5. So
Yes, sir.
the patient understands that an RP5, they'll need full palatal coverage, correct?
He does. Yes, he does.
Perfect. Perfect. Good. Okay. So, Doc, you did take, that would have been S2 when you went through.
Yes, sir.
So,
Yeah.
where were first of all, how many implants did you want to place?
4. I was thinking about 4, but I mean, I'm
Okay.
open to more if you think
Okay.
it would be better.
And where were you thinking, Doc, of placing those implants?
I don't have his chart in front of me. I apologize. I'm in the middle of patient care. I just took a break because I wanted to be here with you.
Okay. Oh, you're in California, right?
Yeah.
Okay. Okay. Can you see the screen?
Sure can.
Okay. So the patient has what, 4, 6, 11, 13, and 15. So, here, let me make it easy for you. So ideally, usually, Doc, unless there is very, very high force factors, we're looking at 4 implants.
Yep.
Now, with an RP5 prosthesis, usually we're doing independent, like locator attachments, so it wouldn't be a bar.
Right.
So if I look at the scenario right here, because it is an overdenture, because it's tissue supported, we need those implants in a strategic position, especially where they are not going to impinge on the aesthetics or decrease the rigidity of the prosthesis. So we have to be very careful we don't put the implants too close and not too anterior. So if I look at this position, this case, obviously you have those first bicuspid areas. As you know, that's our favorite implant position because it's almost always in front of the sinus. And then usually for an overdenture, we try to get a little bit more anterior, but we don't want to go into the centrals because when we get into the central, that decreases the amount of room you have to put a locator attachment and to put a natural tooth or a denture tooth. So usually we'll put 4 implants and let's see what Dr. Hussein, did you work this up?
Yes, sir, I did. So I did add 4 implants, Dr.
Okay,
Resnik. I
perfect.
went ahead with the side of number 5, 7, 10, and number 12, sir.
Okay. So Brian, what heat treatment planned is perfect because first of all, let's see. Let's go through some cross sections and see what it looks like on cross sections.
Here we go, Professor. So for the first implant for the side of number 5, sir, I got a
Okay.
4.3 by 8 millimeter long implant that side, Dr. Resnik. I'm
Okay.
clear away from the anterior of the maxillary sinus, leaving the restored space over here is a little bit tight, Dr. Resnik. It's 8.0 millimeters from the implant platform to the occlusal plane of the patient existing dentition at the side of number 5, sir.
Okay. Perfect. So let's go to number 7. That's 7,
Yes,
3,
sir,
5.
3.5 by 10 millimeter implant at the side of number 7, sir.
Okay. And let's go to the other side.
Then is a 3.5 by 10 millimeter long implant at the side of number 10, sir.
Okay. Perfect.
Then at the side of number 12, I'm using a 4.3 by 8 millimeter long implant that side. and clear away from the maxillary sinus, clear away from the extraction sockets as well, Professor.
Okay.
And yep, that's pretty
Okay,
much it, sir.
let's go back to 10 a second.
Here we go, sir.
Okay. Let's okay. No, you're good. You're good there. Okay. What's the restorative space there? Just
Restorative
on
space,
10, on
Professor.
10.
On 10, if I'm taking it to maybe the cuspal of the adjacent tooth,
Okay, that's a
it's
little bit
a
more. Okay.
yeah, it's
So
11.8 over here.
so Brian,
Yes.
let's go back to the 3D on this. So I like what the treatment plan on this for a couple reasons. Number one, you could put the implants in and leave those teeth in as a basically to allow him to function while they're healing. Number two, we stayed out of that 8 and 9 position, so we're not going to impinge on the aesthetics. I like where he has them a little bit more lingual, so that gives you a little bit more space. The only issue that I see, Doc, is your restorative space. Now, remember, restorative space is from the bone level to the opposing dentition. So on the right side, you only had 8 millimeters. That's not enough for a locator attachment. And that's with doing an osteoplasty or an alveolectomy. So what I'm going to suggest on this patient, is this a male or female?
It's a male.
Male. Okay. Um, is this patient's vertical a little collapsed, do you think? Possibly?
Possibly.
Okay. So I think what you need to do is reestablish his vertical. Now, I if I just look at this, you can kind of tell it probably has because of the lack of or the loss of teeth.
Hmm.
So the way that you can tell, have you taken our pros course, Brian?
I have not.
Okay. If you email me, I'll send you we do a lab on facial measurements. So you can evaluate the patient's vertical just on facial measurements. They're very, very accurate. I would tend to say that you're going to see this patient is probably a little closed and you can't open them up. And then what you could do very easily is use a treatment prosthesis uh, to open them up a little bit to see how he is doing. On this case, what would be really easy is to use a smile transition from Glidewell. That's like a snap-on smile, goes right over the teeth. You could open the patient and see how they do to make sure their joint is fine. And then the last is speaking spaces. So if you look at those 3 criteria, the facial measurements, treatment prosthesis, speaking space, I bet you in the final prosthesis, you can open this patient up a little bit, give you a little bit more room for your locator attachment. Okay.
Okay.
So what I would do is I would do this. You probably want to do this guided.
Yeah.
You don't have to do it fully guided, but just at least pilot or universal, and that will put you right in the ballpark. I think Dr. Hussein can parallel those a little bit
Yes, sir.
and make them perfect for you. And it's a slam dunk because it would most likely be a tooth supported guide, Doc. It would be very easy surgery for you. And also, you can maintain the teeth while the implants are healing.
Okay. So you recommend going that route, Doc, and then
Yeah,
taking them out when
yeah,
I go to put locators or go to put attachments on?
yes. Then you can go ahead and you can do it also this way, Doc. You can as it gets closer to the uncovery of those implants, you can take the teeth out and put a interim full denture in and increase that vertical at that time and actually let that patient adapt to that vertical also. But you can try it out in a smile transition also and see how they do. Just make sure they don't have any neuromuscular issues.
All right.
Okay,
Thank you
any
so much.
questions?
Thank you, Doc. I appreciate your time.
Okay, take care.
Take care.
Okay, let's go to case 2. Who do we have?
Case 2 is for Dr. Krashish. Doc, would you mind please
Oh,
unmuting
George.
yourself?
Okay, now if George is submitting a case, this is going to be a tough one.
Hi, Dr. Resnik.
Okay.
How are you?
Hey, George, how are you?
I'm good, good.
Okay, I know this is going to be a good one. So what do we have, Doc?
I have a patient, Charles Lee. He's 54 years old, and this patient hasn't been to a dentist in a long time.
Okay.
And he came in. He wants to get FP3 for upper and lower.
Upper and lower, is that what you
Upper
said,
and
Doc?
lower, yeah.
Okay, let's first start looking at the upper, George.
Right.
So can we do a cross section through starting molar to molar?
Yes, sir. Right away. I'm
So
gonna
I'm
start
going
at
to have
cataract number
Dr.
3, sir.
Hussein, just so everyone knows, we're going to evaluate in a cross section all these teeth, and he'll go from one molar to the opposite molar and just evaluate what the teeth look like, how much bone is left, and any infection, which this patient has a little bit of all. Okay, keep going.
I did do a cleaning for him to remove all the calculus, you see.
Good idea. Okay, good idea. Um, okay.
And that's it, sir.
For the people on the webinar, if what Dr. George just said is he did a cleaning. The reason you want to do a cleaning, even though these teeth are terminal and they have to be removed, let's go to the 3D. It'll be easier to discuss it. It will decrease the bleeding and it decreases the bacterial count. So it makes your surgery a lot easier and the tissue will heal a lot faster. Let's go ahead and take those teeth out, extract them for us. Okay. So here's the problem that we have, George. As you see, there is almost no bone left from our opposing landmarks, our nasal cavity and the sinus. Did you notice that?
Yeah.
Okay, so after you take these teeth out, the bridal infection, you're going to even have less bone. Once it remodels, this patient is going to be a division D maxilla. Okay, so my recommendation right off the bat is here, let's go to the pan maybe on this.
Right away, sir.
It'll be a little bit easier to see. Okay, see how there's almost no bone here? I mean, they're in the nasal cavity and in the sinus. So, George, what I'm going to say is your two options or your three options are one would be conventional prosthesis, just a denture. Two would be a extensive bone grafting that we would not know how extensive until after these teeth are out and it heals about 2 to 3 months. So if the patient really wants an FP3 with conventional endosseous implants, take out the teeth, let it heal for 2 to 3 months, rescan it, then we'll reevaluate it. It's going to definitely be bilateral sinuses and some really significant grafting in the anterior. The third option would be zygomatic implants. Okay, for this gentleman for fixed prosthesis. But again, that won't be able to be determined until the teeth are out. So for the maxilla, no matter what, they need to be taken out. The patient's going to be in a denture. And I'll tell you, George, a lot of times patients, they get into a denture. I know you're very gifted and a very good clinician. You could probably make a good denture where they probably wouldn't want to go through all those really invasive procedures. That would be very unpredictable also.
I agree
I
with
don't
that.
even know if they have bone there for the zygos. I mean, there's almost no bone left anywhere there. So does that make sense, George?
Does, yeah, absolutely.
Okay. So let's go to the mandible and let's see if that's a little bit better.
Yes, sir. I'm gonna look right away.
Okay. From what I see, George, it looks like the same, right?
The mandible is a little bit better. Actually, it has good bone in the mandible.
Okay, but the teeth have to be removed.
Yeah, yeah.
Okay. Okay. So what he's doing now is he's rebooting this so we can see the mandible. And I'm going to ask Dr. Hussein to start from one molar and go to the opposite molar.
Here we go,
And
Professor.
so he's going to blow that up. So what we're looking at again is infection, where the teeth are, and how much bone there is between any of the vital structures, which is mainly the inferior alveolar nerve. Okay, keep going. Okay. And this is a male, correct?
It's a
You
male,
said
yeah.
in male. Okay. Okay, let's go back to the 3D. So now on this one, George, what I'm going to say that you are 100% correct. Number one, we have super eruption of those teeth. So you have dental alveolar extrusion. See how high those anterior teeth are compared to the posterior. So
Yeah.
you're going to have to reestablish all the maxillomandibular relations, tooth position, and vertical on this. However, the good news is that you have good bone between the foramens. So you can put 5 implants in. You won't have enough bone posteriorly, though, unfortunately. So who's Dr. Hussein, did you work this case up?
Yes, sir. I did add 5 implants intraforaminally, Dr. Resnick, at the A to E position, sir.
Okay. Let's look at a cross section of those, if we could.
Here we go, sir. I'm going to start with the A position, Dr. Resnick. So for the A, we do have a 3.5 by 11.5 millimeter long implant over here,
Okay.
covered with good bone all around, sir, clear from where the loop anatomy is. Then we've got the B position, Professor, 3.5 by 11.5 over here, engaging good native bone all around. Then we've got the C position, which is
Okay.
still a 3.5 by 11.5. The next is the side of number 22, 3.5 by 11.5 at the D position. Then lastly, sir, a 3.5 by 11.5 at the E position, clear away from the lobe anatomy. And yep,
Okay. Okay.
what is you,
So
sir?
with this one, George, I think you can take those teeth out. Not a problem. Uh, and place the implants at the same time. I would also clean this tissue up, clean these teeth up as well as you can. Definitely put the patient on chlorhexidine a week or two prior and get that tissue as healthy as can be. Um, he can tweak those implants to make them perfectly ideally positioned and parallel. And I think your AP spread looks good, and I think you'll be good to go on this
So
one.
awesome. So it will
So,
be conventional denture on
yeah.
over
So what
teeth.
I would recommend, and I'll tell you, George, I probably over my 35-year career batted about 80% on this. On these type of cases where there's really an atrophic maxilla, the patients, they're going to be in a denture for a while anyway, while it's healing. They kind of get used to an upper denture. The mandible, they're going to have a real hard time at a mandibular removable prosthesis, especially on this case. But with doing the implants at the same time, you can immediate load these. So I think your options are endless on the bottom. So you could do whatever you want. You could take the teeth out, let it heal, then place the implants. Or like I said, take the implants out, place the implants at the same time, and up to immediate load it. And it's going to be against the opposing denture. What I would do first is take out the upper teeth. The reason is, George, this patient has significant periodontal disease. That means they have a ton of periodontal pathogens. Just by removing one arch, when you remove those teeth, you remove all those pathogens, it cuts the bacterial count in half. Secondly, your mandibular position, your teeth position is going to be dictated by the maxilla. So by taking the maxilla teeth out first, it'll give you more time to play with the aesthetics of that. And then if the patient doesn't like the denture, then you can talk to them about extensive bone grafting or zygomatic implants if they're candidates.
Right.
Okay?
Yeah, sounds good.
That makes sense?
Perfect. Yeah, absolutely.
Okay.
Thank you so
Okay,
much.
take care. Okay.
You too.
Okay. Who do we have next? We got some good
Next case,
You're right.
Professor.
We do have some good cases.
Yeah,
Okay,
they're
go
all
for it.
great.
Yeah.
Dr. Benefield is our next case, Professor. Dr. Benefield, would you
Okay.
mind unmuting yourself?
How's our superstar doing here?
Dr.
Hmm.
Maria.
Is she here?
Yep, she is here,
All
sir.
right. Sorry, I couldn't find the mute button. My apologies.
Okay.
How
Hi,
are you
Maria. How
No
are
doing?
worries.
you?
Good, very great. How are you?
Good, good. So what do you have for us tonight?
So I have this, he is 80 years old, very, very healthy. He has this bridge from 9 to 12, and
Okay.
9 is failing. I'm sorry, 9 to 11, my apologies.
Okay.
And 9 is failing. So I discussed because number 8 is an implant, it would be very challenging to do. And because of his age, he was concerned, but I explained to him he's very healthy. He takes a baby aspirin, not on Eliquis, and takes a cholesterol injection, 1 millimeter injection every 2 weeks. So in excellent health. So I can see him living till 100.
Okay. So, quick question.
Yeah.
Let's look at it straight on. From-
His
Did this
smile line
patient
covers.
say that again?
When he smiles, you cannot see the gum line. So that's,
Okay.
yes.
Does he have a diastema there, or is that the CT scan?
No, what's going on is that it's the bridge is coming loose.
So it's facially positioned?
Yes, so that's the issue with him. He has a very strong inclination. He's a bruxer. I've been asking him to wear a guard. He refuses. So the force actually is what has caused this bridge to fail.
Okay.
And
Okay.
number 9
So,
is an endo-treated tooth. So,
yeah. So let's just bring that incisal edge down a little bit, Dr. Hussein, so we can show
Yes.
them other way. I want to show them how the number 9 is a little bit longer. Okay. So
There we
it
go.
looks like, yeah, that whole tooth has been splayed facially.
Oh yes,
Um,
all of his teeth are very facial. They're inclined, uh,
okay.
positioned inclined.
Okay. So let's take a cross-sectional view and let's see what the bone looks like. So let's start at 8 and move over to 9 if we could. So let's look at, do you know how long this implant's been in?
It has been in there for over 20 years.
Okay, great.
Yes.
Perfect. Okay, so let's scroll through. Okay, so this is number 9. Wait, stop. Okay. Okay. So right off the bat, Maria, when you take that tooth out, which is probably
Hmm.
ankylosed, that whole buccal plate,
Gonna be
what is
gone.
left of it is going to be
Yes.
gone. So you're
Yes.
not going to have any bone there. Um,
I've already
th
decided to bridge 10 and cut out the crown on 8, if you agree. My
okay.
thoughts were remove 9, graft, catcher's mitt over 10, GBR, place the implant over 10 because 10 has, if you look, it has really good bone, and then bridge once it heals, make a small transition from Glidewell, which I haven't made one yet. So I'm
Okay.
excited to try it on him so that it doesn't touch the graft. If you think
Yeah.
it
Okay.
could
So
touch the graft,
let's keep going and let's look at 10.
because 10 has pretty good bone, I think, except for that little
Here is number
catcher's
10
mitt, which
size,
I
sir.
Okay. Okay. Dr. Hussein, did you put an implant in here?
Yes, sir. I did add 2 implants at the sides of number 9 and 10. I'm going to start with the side of number 9, Professor. So for number 9, I'm using a 3.5 by 11.5 millimeter long implant over here. The thing with that
Okay.
implant, Dr. Resnick, is that it's a little bit too close to where the
Yeah,
the
it's
pinky
too
nail is,
close to the nasopalatine.
and
Okay.
too close to the adjacent
Two.
implant as well, Professor. 2.3
Yeah.
millimeters in between 9 and 10. For 10, I do agree with Dr. Benfield. We do have better bone over here, but I had to use a 3.0 by 11.5 just because of the musical space, and I'm 1.5 millimeters away from the laminate to that
Okay.
adjacent tooth.
So let's try this, Dr. Hussein. Remove 9 implant.
Yes, sir, here we go.
Okay, and make number 10 a 3.5. Let's see what it looks like.
We're looking great,
Oh,
Dr. Resnick.
I can deal with that. That's okay.
yeah.
So Maria, I like your idea about this. So let's just talk about this implant. This
Yes.
implant's been in 20 years. There's
Yes.
minimal bone loss around it. That
Yes.
that is part of his skull. You're not removing that implant. It's in even
Oh,
force
no, I don't
won't
want to
hurt that.
touch it. No,
Yeah,
no.
well, the reason I'm saying that is normally we don't like to do this
Mhm.
bridge it in a patient with high force factors. But
Uh-huh.
with this circumstance, I don't think number 9 will ever be a good site. Um, First of all, to take that tooth out, you're going to destroy the rest of that bone. And to
Yeah.
graft that back to where you could place an implant in an 80-year-old, it's not going to happen.
Okay.
I think our best bet is to do what you originally said, to bridge it from 8 to 10. But
Okay.
what we have to do is prevent what destroyed number 9 from happening to this prosthesis. So let's go back to the 3D image.
Here we go,
So,
Professor.
so here's what I would check on him. See, wait, let's show everyone the lower teeth.
Lower teeth.
Yes, you can see right there.
Okay. So this patient doesn't clench, they brux.
Yes.
Okay. So the reason why they destroyed 9 is he's coming forward and his anterior guidance is
Yeah.
just beating up on that number 9 or that bridge. So I think that you'll be able to cut the bridge between 10 and 11 or 10 and 11,
Yes, yes.
leave 11 as is,
Yeah.
or redo the crown, whatever needs to be done, bridge it. But when you make the prosthesis, you have to make sure that the anterior guidance is a quick disclusion. Do you
Yeah.
remember we talked about that at the pros course?
Yes.
We talked about it when you have a cuspid implant on one side, natural implant on the other. You want to disclude quickly, meaning you don't want him hitting on the lingual surface of that fixed prosthesis and sliding. You just want him to disclude enough to where those posterior teeth disclude and don't touch. Now, he's done the job for you because he's already ground down the teeth. So you don't
Yeah.
really have to modify the uppers. You just have to make sure that the you need to make sure you have enough restorative space, which I think you will.
Okay.
Secondly, especially where he has that implant, he has it in a good position. And then secondly, make sure when you put the prosthesis in that you have him come into protrusive and
Okay.
also a lateral protrusive to make
Hmm.
sure that he is not hitting on that prosthesis high. Okay. Does that
Okay.
make sense?
Absolutely.
Okay.
Yes.
Secondly, I would highly recommend an occlusal guard.
Oh, yes.
Okay.
Yes.
Um, if he declines, make him one anyway.
I was
Just
planning, I have a sprint race, so I was gonna make, and I usually when I do implant cases, I do gift them a flex
okay.
guard.
Okay, good, good. And he needs it. And he's 80 years old. He's
Yes.
going to be fine. So, just for everyone on the webinar, remember an 80-year-old patient, even though they're healthy, they have a poor blood supply. They
Yeah.
have poor peripheral perfusion. That means that they don't heal as well or heal as fast. So, some people would attempt to do a heroic bone graft on 9, just to put another implant in there. That's not in his best interest, not at all. Uh, Another thing that you could do, Maria, is
Yeah.
if those lower teeth look really worn down,
Yes.
you could make him a permanent um, smile transition on the lower to
Oh,
where, and you could fix his occlusion just with that. Just you probably have to remake it every year,
oh
but
boy.
it would look well. The only thing you do is you take one impression or you take a intraoral scan, and then you always have it. So
That's
they
true.
just remake it. It's not a big deal, but that would make it aesthetically more pleasing and give you a better occlusal harmony. So that's
Okay.
another possibility. But I like your idea, 8 to 10. Good. Just make sure the occlusions, you just be very careful on the occlusion. Okay.
When I place, my thoughts were, and let me see if you agree, extract 9, place a bone graft, even though I am not planning because I know that buccal wall is going to be destroyed. place an ice cream cone technique, membrane, bone graft, and catcher's mitt. Can I go ahead and place the implant on 10 since the
Yeah,
bone is ready?
so I tell you what I would do, Maria.
Yes, yes.
You're never going to place an implant in that 9 position.
Right,
Just
right.
I
You just want
wouldn't
to
even.
preserve the
What
bone.
what I would do is I would probably there's few indications for a xenograft. This might
Oh,
be a good
okay.
opportunity because it would plump up the tissue and it would hold that tissue. Um, and I would just I would just use a collagen membrane, put some
Okay.
xenograft in, and go ahead and place number 10 at the same surgery. Yeah.
And the GBR and the catcher's mitt, or don't
Yeah,
worry about the catcher's mitt.
yeah. I don't think, to be honest with you, when you take that out, Maria, I
Yeah.
don't think you're on much bone left at all. So
Okay.
you don't
I
want
mean,
to put
over
it
10.
over 10. Oh no.
Yes, yes. Not
Oh,
necessarily.
you could if you flap it,
Yes.
you could put some bone over that um catcher's mitt. What she's talking about is a concavity, but where he has that implant, I don't think you really need to because
Okay.
there's plenty of bone on the facial.
Wonderful. It'll save him money, so that'll be good.
Exactly. And
Yeah.
it'll be less surgery. So
Okay.
I just take the tooth out, put some xenograft in, place the implant. It's a home run.
Wonderful. Thank you
Yeah.
so much.
Okay. Take care, Marie.
Have a good night.
Okay. Who do we have next?
Dr. Cohen is our next doctor. Dr. Cohen, would you mind please unmuting your mic and presenting your case, Dr.
Wow, you
Resnik?
really do have some good cases. Is this Sam?
Yeah. Hi.
Okay. I know your brother's out at the bar or something, so
Yeah.
you're probably
Right.
still working. Uh, by the way, congratulations. You just had a, little
Yeah.
girl,
Little
was it?
girl.
Okay. Great.
Yeah. 4 months
Congratulations.
old. Yeah. Thank you. Thanks.
Okay. Now you see how Christopher feels, no sleep.
Yeah. Jeez. I know.
Okay. So if you're presenting a case, I know there's a story on this one, so let's hear it.
Well, yeah. This is my partner's dental assistant's father, who's
Okay, wait,
Albanian.
your partner's okay, I got it. Go for it.
Partner's assistant's actually father-in-law.
Father-in-law.
Makes it even more complicated.
Okay.
The guy's Albanian. He went to Albania and had all his implants put in, and I asked her, why didn't you have me do it? I would have given him a good price, but he had it done for like $3,000, which I was like, I can't beat that.
Is that a fixed prosthesis?
It's a fixed prosthesis. I think it's multiple bridges cemented over what looks like stock abutments.
Okay.
They're PFM. So I think they kind of just put the implants in, and I don't
Yeah,
know.
you know, these might even be one-piece implants, but
They could be.
meaning the abutment and the implant are all one piece. So,
Yeah.
okay. So let's go ahead and so what's the story on or
Well, he
what's
came in with pain,
okay.
and my partner couldn't figure it out because they're all implants. He thought number 9 was infected. So I took a
Okay.
CT scan and
Okay.
look at the CT scan. We
Yeah.
see number 9 is in the
Yeah.
nasopalatal.
So Dr. Hussein, show everyone, blow that up. You can see the actual implant in the nasopalatine. So that's a good one.
Yeah.
That'll be going one for the textbook. Okay. I
Yeah.
have to get that one from you. Okay. With that being said, let's do a cross section of that. So, from what I hear is, when was this done? First of all,
He said like a year ago, or maybe a
okay,
year and a half or two. It was pretty
okay.
recent.
So they did a pretty good job of getting it into the canal.
I don't
Okay,
even know how they got stability on that implant.
yeah. Probably. Is it splinted to another implant? It looks like it might be splinted
I'm
to
sure. I'm
eight.
sure it is. I'm sure it
Okay,
is. But
okay,
I don't
okay.
know. I
So,
he's probably going to end up. I think he's going back to Albania to have it treated. Because I don't know what can be done with this.
okay, so here's what you want. Let's just go on the assumption he's going to have you fix this.
Okay.
So, if we just look at this localized problem, he's having pain in number 9, correct?
Mhm. Yeah.
Okay. Where is the actual pain? Is it on the palate? Is it on the tissue? Is it when you touch number 9? Did
The
you
problem,
evaluate that?
yeah. Well, the problem is I can't really communicate with him because he doesn't speak so well
Oh,
English. So
anything else wrong with this case? Okay. So let's look at
So why are you
the biology of this. So if we have an implant in the nasopalatine canal, what nerve is in the nasopalatine canal? The nasopalatine nerve. Okay.
Mhm.
And what does that innervate? Well, that innervates the anterior palate. Also, we have the sphenopalatine artery, which nourishes the nasal mucosa in that area. So
Mhm.
the problem with the nasopalatine uh, canal being infiltrated by an implant is that in the old days, I'm saying 30 years ago, we used to go in all the time and just take out the nerve and the artery, stick an implant right in the midline. That that has kind of fallen out of favor to where we try not to even impinge on the nasopalatine. This one, they went right into the canal. So
Mhm.
the implant's definitely in the canal. If it's been a year, what
Mhm.
my belief that you have going on here, Sam, is that the patient probably didn't have pain right away. It probably developed over time and it'll probably get progressively worse. What happens when you destroy nerve tissue or you irritate nerve tissue? It will form a neuroma. You remember
Mhm.
us talking about neuromas?
Mhm.
It's like scar tissue that forms around that nerve. And when you get a neuroma, it's a very high incidence of not getting so much a paresthesia or an anesthesia. You get dysesthesias. So if you remember what a dysesthesia is, it's a painful response to a nerve.
Mhm.
So this patient most likely has a neuroma formation from the destruction of this nerve by this implant. So what do you
Mhm.
do? So, Dr. Hussein, can you draw
Yes, sir.
okay, here's what I'm going to tell him what to do. Maybe you can draw this. You don't have to take the prosthesis off. All that you do is you flap the facial and you cut off. No, okay, there's a facial. Now make a line. Um, Basically, what I want him to do is just cut the base of the implant out and leave the prosthesis. So make a perpendicular line to the implant. Okay, from the long axis.
Uh,
Um,
this way, Dr. Resnick, like
yes,
with the
but
red.
higher. So go up to the basically the CEJ of the implant, a little bit higher. Keep going, keep going. Okay, right there. So what you do is you take a crosscut Fisher burr on the buckle, remove that bone, just cut the implant off, take the implant out of the canal and let it heal. That's the most conservative approach to that. Uh, the cases that I've done like that, it usually resolves those symptoms.
Mhm.
In a rare case, it wouldn't resolve the symptoms, and then I would go in and nucleate the whole nerve and take out the nerve.
Okay. If
Okay,
it doesn't
but
resolve.
you always want to do the most conservative approach first.
Mhm.
And this approach I just showed you, you get to keep the prosthesis. It will be very simple to take that part out. You just what you have to do is polish the underside, the intaglio surface of that prosthesis so it's not sharp. And
Mhm.
then aesthetically, he might have a little bit of a soft tissue opening there, but it is what it is.
What about a palatal approach, or you would do the facial approach?
Yeah, you can go palatal. It's really hard to do. And you have to go through, it's deeper going from the
Okay.
palate.
Okay.
Yeah. So see where his line is there?
So you have to
You,
cut the bone to
yeah, but you
feed it
can go up
through.
a little bit higher. Yeah.
I'm just
So
wondering how you pull that implant out of there. You have to cut part of the bone out.
bone out, yes.
Yeah.
Yes.
Okay.
So you just it's almost like you're doing an apicoectomy. You keep
Yeah.
removing the bone until you get to the implant, and then you just pull it out with some small hemostats.
All right. Well, if he has me do it, I'll have my brother put a GoPro on and record it.
Record it, and then what's my saying about taking out other people's implants? Do you remember?
Ah,
You take your
no.
normal fee, you
Oh
multiply
yeah.
by
Yeah.
5, and then you
Yeah.
think about not doing it.
Exactly. I remember
Okay.
that.
Okay. But that's how you do it. If you do end up doing it, call me before and we'll walk you through it again. Okay.
Okay. All right. Sounds good. Thank you.
Okay. Take care.
All right. You too. Thanks.
Okay. Okay. Dr. Hussein, who do we have?
Dr. Curnew is our next doctor. And Dr. Curnew, are you in the line with us? You're going to need to unmute yourself, doctor. We can't hear you. Let me
Dr.
help you with
Canoe, can
this.
you unmute yourself?
Yes, I managed. Thank you.
Okay. Hi. How are you, Doc?
Hello, I'm fine. Thank you. Thank you
Good.
so much
Okay,
for
good.
helping me with this.
Okay, good. So tell me a little bit about your case.
So the patient is a 57-year-old gentleman,
Okay.
super healthy, no medication.
Perfect.
He is only allergic to penicillin, true allergy, and he did this. It's a trauma. He opened bottles,
Okay.
a beer bottle with his front teeth and knocked them out. He has been
He
like this for over 5 years, and the extraction was done. I don't know, in a different office. So he came to me and said, I'm tired of stay plate. Please, let's do something.
okay.
So he wants
So
implants.
so he opened a beer bottle with number 7 and 8.
7 and 8. Yep.
I got it.
So
Okay.
quite expensive.
Okay, yeah. Probably don't do that again. Okay, so what I'm going to have Dr. Hussein do is start at 6. We're going to look cross-sectional. Let's see what our bone looks like.
Here we go,
And
Professor.
so that's number 6. He's coming anterior. So the bone looks pretty good there, Doc.
Yeah.
Looks really good. Okay, and then we're in the midline, so we don't need to know about that. So good. So, Dr. Hussein, did you work this up?
Yes, sir. I did add 2 implants at the sides of number 7 and number 8, Professor. At the side of number 7, I'm using right now a 3.5 by 11.5 tapered implant, good bone coverage to the facial and to the pathal aspects, sir. Perfectly clear away from the laminate dura, 1.5 millimeters exactly to the laminate dura of the adjacent cuspid tooth. 3 millimeters in between implant number 7 and implant number 8, Professor.
Perfect.
8 is a 3.5 by 11.5 millimeter tapered implant as well. Clear away from the nasopalatine canal, sir. And if I take you back to the 3D image, Professor, we've got a beautiful positioning for those 2 implants over here. What's your thoughts, sir?
I like it. I like the positioning. It's going to be a perfect screw retain prosthesis. You just barely have enough bone, Doc, to do this. So I'm glad that he is deciding to do it now instead of a couple years from now, because if you wait any longer, you're going to have to bone graft this. If those implants are placed exactly where he has these, it'll be a perfect ideal case. The only thing I would recommend, Doc, is I would splint those 2 implants.
Okay, that was my question.
Yes, yes. It's a male. Um, Biting force is going to be higher. They're 3.5 implants. Um, we can't get wider implants in because of the mesial distal length. There won't be enough room. So the way he has it with 2 3.5s, I think is perfect. Uh, and I would do this guided with a 2 supported guide, and I think it would be a home run. Prosthetically, just be careful. It's going to be similar to that last case where I said, just be careful the guidance on it, that you don't ride and have too much shear force on it. But by splitting them together, it's going to be exponentially stronger, and I think it'll be perfect. So this case is where he has them right now. I leave them and go for it. Very good case.
I have one more question.
Yes.
I took this CT scan in October.
Yes.
Do you think I need to take a new one?
No, not at all.
I will be
No,
good.
you're good. You're good to
Okay.
go. You're good to go. Yes. So it, it that's what, 4 months?
Yeah.
Yeah,
Yeah.
approximately, sir.
Usually 6 months, even 8 months, we're good with it. And
Okay.
um, I'd be worried if it was a year and a half. That'd be a different story. On this case, let him know he needs it done yesterday. So get him in and do it.
Thank you so much.
Okay. Okay, Doc. Good luck. Let me know if
Thank
you
you.
have any questions. Okay.
Last case for the day, Professor,
Okay.
is for
Last case. Who do we have?
Dr. Jake Shirk is our last doctor for the day, sir.
Hi, Doc. How are you?
Doing well. How are you?
Good. So, what do you have for us tonight?
I have a new patient. He came in for consults for implants, two broken down teeth that are hopeless. So, plan on extracting, but the current state going to need grafting.
Okay.
The main question is, should I risk trying to extract, graft, and implant, or extract, graft, wait, and then place?
Okay.
Usually
So,
I extract and graft and wait.
okay. So let's first look at what teeth are we talking about, Doc?
So number 4 and 12, I believe from memory. Sorry,
Four,
Yes, sir.
4 and 12. Yeah, that's what
Yep.
it looks like. Okay. So let's first start at number 4. I'm going to have Dr. Hussein do a cross-sectional view of this.
So there's a pathology noticed at the side of number 4, Professor,
4.
as well as perforation of the or festration of the labial plate of bone over here as well as the lack of any recipient bone or host bone, sir.
Okay. Okay. Don't move from there. Just leave it right there. And is that a lot of decay I see? Is this a blowout on this
I
Yeah.
tooth?
think it's
Yeah.
decay. I think it's decay.
Yeah.
Yes, sir.
Okay. Okay. So for the people on, just so everyone understands, when we look at taking a tooth out and placing an implant, we always look at how much bone we have. Usually we need 2 to 4 millimeters of bone apically, and then we need bone on the buccal and on the lingual. The problem with this particular tooth is when it's taken out, we need to debride that. By the time you debride it, you're going to be right up to the inferior border of the sinus. So there's not going to be any bone left here. So uh, the second question we ask is it graftable? So we know we can't place an implant. However, can we take the tooth out and actually graft it? So the first thing I'm going to ask you, Doc, is this a new patient, did you say, or is this an older patient?
Newer patient to
Newer
me.
patient. So
Yep.
you don't know how long this infection's been there?
Correct.
Okay. So when we look at why I asked you that, people may say why. The reason is when you have a chronic infection, what ends up happening is it changes the pH of that area. So ideally, bone, which is normal, is ideal in health, is about 7.2 pH. When you have a periapical infection like this, Doc, it can go down to 6. So what does that mean? Well, that means that if we leave part of that necrotic bone or infected bone in there and graft over top of it, our graft isn't going to work very well, or it has a higher chance of morbidity.
Hmm.
Now, if I look at this, scroll 1 click or 2 clicks each way on this, Dr. Hussein. Let's just
Royally,
take a
sir.
peek. Okay, go back, go back, go back. 1 click, one more. Stay right there. Okay. That's probably the most extensive part of it, Doc. I think you can remove that and graft. The only thing that I'm going to recommend is that if the bone is not bleeding, then you don't want to do that and you want to remove more of the bone. I want you to get the good bleeding bone. You might even have to decorticate it to get it bleeding, and then go ahead and graft it. So the bottom line on this case is, Doc, I would not take it out, put an implant. That would not be good. I
Yep.
would either take the implant out, debride it real well, bone graft it, or another option would be just to take the bone tooth out, debride it, let it heal, then go back in knowing that you're going to have to graft it again. Okay.
Okay.
Now, one thing I do want to caution you on this is when you write this treatment plan up for the patient, make sure you call this a preliminary graft. The reason is, even though you graft this, Doc, you might have to do a sinus bump on this later.
Yep.
So by calling the first one a preliminary graft, let them know that 2 to 3 months after that, you're going to take a new scan and you're going to determine if you have to place a second graft. Does that make sense? So now
Yep. Yeah,
the
makes sense.
patient understands that, okay, the second graft isn't because your first graft didn't work. It's because anatomically you had this infection. You knew it from the start. And so there's no miscommunication and there's good consent on that. So the way that I write it up, phase 1 is extraction, graft. Phase 2 is a CBCT and second bone graft to be determined. And then your implant, which could be phase 2 or it could be phase 3, depending if you need a full-blown graft into the sinus or not. Okay?
Makes sense. When it
Okay.
comes to your choice there of extraction and just letting it heal and then going back for like GBR later, you're basing that basically off the bone bleeding at the time of extraction?
Yes. So if you have basically necrotic bone there, you're not going to want to graft into it because, like I said, the one thing you don't know is how long this infection's been there. That infection was there for 10 years sitting there. That whole area, the pH is probably compromised. Now, when you take the tooth out, what happens in those cases, Doc, is the patient's immune system takes over and cleans that out itself, and then it changes that pH back up to 7 or so. What I want you to do is go in, and even if you have to decorticate it, that brings more blood in, blood vessels or blood cells into the area, mainly macrophages and neutrophils. And what that does is that cleans up the area. So by getting it to bleed more, it's cleaning it out, and that's going to help your bone graft.
Yep, perfect.
Yeah, but to be honest with you, if you want to be the safest, take the tooth out, debride it, and just let it heal. I think you can graft it though. I think there's enough still host bone there that it would be you'll be able to. Okay.
Yeah. Yep.
Okay, let's look at the other side.
Right away, Professor. Here we go. So
We have the same thing on the other side.
Very similar. Yeah, it's probably even
Ooh.
worse. Yep.
Yeah, now this is going to be a different story. Okay. Let's scroll back and forth on this one. Wow. Okay. Let's look at a pan view of that.
Here we go, Professor.
Okay, so you were right. We did have some good cases tonight. So this one, Doc, is going to be a lot different. You're not going to take the tooth out and put an implant. You're not going to take a tooth out and do a bone graft because if you do that, you're going to be into the sinus. There's too much pathology here. So let's go back to the 3D, the cross-sectional image.
Cross-sectional image, sir.
So this one we're going to treat this one a little bit differently, Doc. So if you try to graft into this area, it'll never take. And you'll probably go into the sinus, which will cause a whole nother issue. So what I would do, Doc, is take out the tooth. On the lingual, you can get aggressive and debride it. On the buccal, debride it aggressively. On the apical area, you have to be very careful. Okay, you will probably leave some pathology there.
Okay.
So what you don't want to do is to graft over that pathology. So what I would recommend is you can take a collagen plug. Have you ever used a collagen plug?
Yeah.
Okay. Take a collagen plug and use a local antibiotic. Ancef is the one that we recommend. You put some Ancef onto the plug. You put it down into the socket. You let the body naturally clean that out. The collagen plug will prevent any food or any debris getting in, and the antibiotic will help clean the infection out also. Okay. Does that make sense?
Yes. Yep.
Yeah.
Would you
So
still recommend like antibiotic prophylaxis on top of that?
yes, I would. When you're going to do both of these same day,
Most likely.
I would prophylactically give the patient antibiotics on this one. Yes.
Okay.
The only thing that I would change though, Doc, is I would um, give the patient instead of amoxicillin, give them augmentin. The reason is you might have I see that little cloudiness in the sinus.
Yep.
You might already have a communication already into that sinus and see where it gets real thin there. I think
Yeah.
there might be a communication. Uh, Augmentin is better for the sinus because it reduces the beta lactamase bacteria in the sinus, where amoxicillin won't. So, as everyone knows, Augmentin is amoxicillin. It just has clavulanic acid in it. So,
Mhm.
prophylactically, if you see our antibiotic prophylaxis or in textbook, just follow the sinus prophylaxis with augmentin.
Okay.
Okay.
Sounds good. Yep.
Does that make sense?
Oh
Okay.
yeah.
Any other questions, Doc?
Nope, that's it. Thank you.
Okay. Okay. I want to thank everyone. Some great cases. I think this does work better by limiting the number of cases. Just please get them in early. You can send a case anytime you want to Dr. Hussein, and he will go ahead and get that worked up. Our next grand rounds is going to be February 11th, so little bit less than a month. Okay, thank you, everyone. Thank you to Dr. Robinette and to Dr. Hussein, and everyone have a great week. Take care. Thank you.
Thank you, Professor.